Childbirth changes a woman mentally and her body anatomically. Stay with us for the next segment of Kentucky Health when we talk about pelvic floor disorders. Hi, and welcome to another segment of Kentucky Health. George Eliot, the writer, and this is a female, said, "I like trying to get pregnant. I'm not so sure about childbirth." You know, it's like childbirth is the gift that keeps on giving. There are often new problems that develop as a woman ages. It's one of these things that you have the baby, but then what happens to the pelvic floor after all that? And that's what we're going to try to talk about today with our guests. First, we have Ms. Heather Lange, who's an advanced practice registered nurse, graduated nursing school down at University of Kentucky and did your advanced practice nursing at the University of Louisville. Heather, thank you for being with us today.
Thank you for
Also, Dr. Sean Francis, who is the current interim chair of OBGYN and Women's Health at the University of Louisville. Dr. Francis is a graduate of Morehouse College down in Atlanta, also went to medical school and your internship at Case Western Reserve, followed by your residency in obstetrics and gynecology at the Medical College of Georgia, and I believe you also did a fellowship in female pelvic floor medicine and reconstructive surgery down at the Mayo Clinic in Scottsdale. Sean, thank you for being with us today.
Appreciate you having me.
You know, I said that childbirth is the gift that keeps on giving because so often in my practice, we'll see women coming in with problems as far as fecal incontinence, other issues, even though they may be in their 50s. But I tell them your problem probably began way back when you had a child. So what is the pelvic floor? I guess that's the biggest thing. And what are some of these problems then?
Well, that's a complicated question. The pelvic floor is it's a complex structure composed of muscles, fascia. These muscles and fascia and nerves work together to kind of support the pelvis and support the pelvic floor anatomy.
So when you're talking about the support there, so you're talking about muscles, what about the structures like the uterus? Does that add support or is that just there?
Well, the uterus itself has support structures. The uterosacral ligaments, some ligaments that hold up the uterus. The uterus itself probably doesn't add as much support. There is, we know that the uterus is somewhat, well, let me rephrase that. We know that removing the uterus does increase your risk of pelvic floor relaxation or prolapse, but it probably doesn't really play a role in support itself.
You know, we all are familiar with the diaphragm, I guess, that separates the abdominal cavity from the chest. Can we think of the pelvic floor as a diaphragm except for down at the lower end?
Sure, you could. Often it's referred to as the pelvic diaphragm, a triangular group of muscles that are right at the pelvic organs. It is sometimes called the pelvic diaphragm. So it's very similar in that it's a group of supportive muscles that kind of float or help float the vaginal organs or the pelvic floor organs.
Heather, so what are some of the problems that a woman may come in if there's a that makes you think this is a pelvic floor problem?
Oftentimes probably most commonly, we see ladies walk in and have trouble. They have vaginal pressure, bulging, they may feel something falling out per se, and sometimes they'll have other symptoms associated with their vaginal symptoms accompanying urinary incontinence, fecal incontinence, pain, trouble emptying their bladders, problems with infection, so a variety of symptoms.
So when you talk about something falling out, is it falling out through the vagina, or is it just bulging out through the structure down there, the perineum, I guess that structure between the anus and the vagina?
Most commonly, I would say they feel something falling out from from their vagina.
And what kind of things fall out? So is it the uterus? What kind of things?
It's the uterus, typically the first thing that comes out. The vagina actually can turn on itself, if you will, so that if you can imagine a sock in its normal state, if you push the sock through the opening, the vagina can do a similar thing where it comes out and it turns into a bulge and can stretch and become larger, and usually that's from inadequate support at that point.
And then I've seen these things before where the bladder also may come out.
And that's a common misconception, if you will, that the bladder actually falls down. Really, the vagina is the main support for the things. The bladder lies on top of the vagina itself, and so if you can imagine that sock again, with the vagina coming down and out, the bladder is behind it and remains inside the abdominal compartment, but the vagina is really what you see when you see that bulge.
So it's not really that the bladder is coming off its moorings and just popping on through. It's just you're seeing it pushing against the vagina at that point.
That's correct.
I would imagine that having this many things coming through the vagina, it must make it very difficult for normal daily life, from passing stool, passing urine, to even sexual activity.
Yes, sir.
Is that something that patients may complain of?
Yes, sir. Oftentimes that's mainly what ladies will come in presenting, that it's affecting their quality of life. They're having trouble with intercourse, they're having trouble with exercise, they're having trouble sometimes just with daily activities, sometimes even walking. It's uncomfortable. And so we do our best to try to evaluate and find them the best management that they're comfortable with.
So how do you go about evaluating? Let's start with you, Sean. What are you doing when you're evaluating these people? Is it just you talking to them, or are you actually laying on hands, or what happens?
Well, I think we're all taught in medical school that the most important part of the evaluation is the physical exam and the history. So the most important part of this evaluation is the history. Initially, we start by talking to the patient and asking them how is this affecting their quality of life, how is it affecting their daily activities, what specifically do they have as far as symptoms? Do they have leaking of urine? Do they have a bulge? Do they experience feeling of pressure as the day goes on? Those are kind of key elements in the history. We then move to the physical exam. The physical exam is really pretty straightforward. We look for the bulge. We evaluate the pelvic organs. We have ways of evaluating the pelvic organs. Specifically, we use a POP-Q examination, which is a pelvic organ prolapse quantification, where it enables us to stage and measure, quantify the degree of prolapse of the organ. Then you can move on to defecography, which is, as you know, evaluation of the stool moving through the GI tract, and some other studies, urodynamics, etc.
What are, because you touched on it briefly, what are some of the risk factors for somebody developing? When you're listening to the history, oh yeah, this is probably what's going on. What are some of those risk factors?
Childbirth.
Childbirth, huh? Location,
That's right,
childbirth,
that's right.
childbirth,
Yes,
childbirth.
sir.
Sound like a real estate guru.
What about other things? What about those patients that may have had surgery, any particular surgical procedures, or any nerve problems or things like that?
So hysterectomy, as I mentioned earlier, it puts you at slightly increased risk. Of course, the more prolapse surgery you have, the more likely you are to fail. Connective tissues get thinner. Any connective tissue disorders, there are people with several different types of connective tissue disorders that we typically see come in a little more often.
What about the diabetic patient? Is this something that they're at increased risk for having these kinds of problems?
I don't know that specifically diabetes is listed among the risks, but we know that diabetic patients that have a harder time healing and will typically be susceptible to most pathology.
Okay. So you have this patient comes in, they tell you that they have something bulging out, and you examine them. Lord, there it is. Something is bulging out through the vagina. You do your evaluation. Now what do you tell them you're going to do, Heather?
Well, we ask them if they're interested in surgical or non-surgical options.
Everybody likes to know the non-surgical, because who really wants to be operated on nowadays? So what are those non-surgical things?
Non-surgical options typically are pessaries, and they are little devices that almost look like diaphragms that ladies used to wear. Not so common anymore. And we've fit patients in the office.
And what does the pessary do?
It's a supportive device, so it sort of sits in the vagina and kind of holds the prolapse back into position. It should be comfortable. It's not painful. And we can teach ladies how to manage them themselves, insert and remove and clean. And if they're not comfortable with that, we can offer that service in the office.
Is there a risk of getting an infection if you have a pessary in place?
Obviously, a foreign object, there's always risk for infection, but we don't typically see too much infection with pessaries, do we?
And the vagina is a place that is not strange to bacteria, so that an infection in the vagina is well tolerated by the body.
I see.
We typically just remove the pessary for a couple of weeks and usually don't even require antibiotics.
Any problem with erosion of the pessary through the vagina or anything like that?
That does occasionally happen where the pessary works its way through the tissue. As you know, anytime you have a permanent type of structure or foreign body in a tissue, where the tissue is moving and the structure is not, there's an opportunity for erosion.
Okay. What other non-operative things do you have?
We have pelvic floor rehabilitation that oftentimes we will refer our ladies out to sort of strengthen the pelvic floor muscles that provide support.
How do you do that?
Well,
Is that the Kegel exercise that you hear so much about?
some ladies, yes, we can encourage Kegling exercises, yeah. But typically we refer for pelvic floor rehab to a specialist, a technician that specializes in, they have further training than we do with those muscles. Vaginal estrogen is another non-surgical option that we use very commonly, and we've seen great results with that, keeping the tissue healthy.
How successful are you with using the non-op things?
You know, gosh, that's a tricky question to ask a surgeon. You ask me, how successful are you? You know, the non-operative procedures, I think most of the data shows that it's pretty successful. I mean, you know, above 20 or 30%, but it depends on what group of individuals you're talking about. We have patients that come in with a wide range of disease in type as well as in the quality of the disease. And so if you have a patient that has prolapse, you know, hanging down near their knees, it's going to be a little bit less likely to be successful.
So the person who comes in pretty early on may do better with that sort of thing. All right, and if the person fails, then what are some of the surgical options available to you?
Well, you know, one of the things we're proud of is that we have a whole host of surgical options, including entering through the belly, and we take pride in the fact that we do most of our surgery in a minimally invasive fashion. So we use laparoscopy, robotic surgery. You can enter through the vagina. You know, there's a host of surgery types. There are some where we use mesh. We can do some of the same surgeries without mesh. We can make sure the patient keeps their uterus if they want to. At the same time, we can do hysterectomies along the same line. So we have a pretty wide range of surgical.
Okay, so before, I want to come back to that mesh issue in a little bit, but what are the fundamental principles that you're trying to achieve surgically when you're talking about repair?
Sure. The fundamental principle is really involved to re-elevate the apex of the vagina and the different parts of the vagina. What
So
do we mean?
raise it up?
Yes. So it's similar to a tent, if you will. Tent has 3 walls, and if you want to elevate the apex, usually we'll either put a pole, a center pole in the tent to hold it up, or you might tie a string to the top of the tent and tie it up to a tree, if you will. Similarly, we take the apex of the vagina and we elevate it toward the patient's head. So that, you know, in some cases the sacrum serves as that tree, if you will, and we might use a piece of mesh as that would be the equivalent to the rope that's tied to the top of the tent.
Are you doing anything to the pelvic floor itself, since that may be weak, or just enough just to pull the vagina up?
You know, that's an excellent question, because we always boast about pelvic floor, you know, reconstruction, but the reality is all you can really do with surgery is reattach the fascial defects and re-support the fascia or those layers of tissue that are connected and held together by the muscles. And I think that's why it's so important to have physical therapy, whether you're doing surgery or not, to help rebuild the muscles.
Okay, so if I'm thinking in terms of that person who comes in with their bladder coming down, though it's not all the way out, you see that. So just pulling the vagina up enough, that's enough to put the bladder back to its normal anatomical position?
Well, in most cases it is, but we will typically resuspend the vagina just below the bladder as well. There's an area called the paravaginal area, and it is directly lateral to the bladder. And so on both sides, you might reattach the vagina and further support it. Again, using the tent as an example, if you resuspended the sides of the tent to, whatever's out laterally, it would add even more strength to that side wall.
What is the advantage of either doing something through the vagina or from an abdominal approach, be it laparoscopic or robotic?
Sure. Well, as far as vaginal hysterectomy, it is still the approach that is felt to be the least risk. The least amount of complications happen with vaginal hysterectomy. So we consider vaginal surgery to be quite minimally invasive. There's a relatively new technique called natural orifice surgery, where you try to use modes of entrance that the patient already has to get organs, and we consider that to be one of the earliest natural orifice surgery. So I think, in short, the advantage is that it's one of the most, or one of the least invasive surgeries that there is.
But what about when you're doing your vaginal suspension and the uterus is already gone, and that may in fact be one of the problems that this patient has? Is it equivalent results when you go through the vagina to suspend, or can you do that, or versus coming from above?
Sure. Well, the data's tricky, and what do I mean by that? Most of the data demonstrates that the vaginal approach will give you about an 85% success rate. Here's the tricky part. The abdominal approach demonstrates an 85% success rate as well. However, the sacrocolpopexy is kind of our gold standard abdominal approach, meaning that's the surgery that's done throughout the entire world with pretty good results, and it's pretty reproducible. That means, most physicians do it in a very similar fashion. And so for the sacrocolpopexy, there are 10-year trials, 10-year studies. There's a lot bigger number of studies available demonstrating that 15% failure rate, if you will. Whereas for the vaginal surgery, there's so many different versions of it, and studies are typically no more than 5 years. So they're both pretty successful. I guess if you asked me which is the strongest, our gold standard would be the abdominal approach, or the sacrocolpopexy.
Now, Heather, surgery's been done, and these patients come back to see you. What's the functional result for these people after surgery?
They usually have a 6-week period of time where they, are recovering and really sore. But typically speaking, the vaginal procedures, they typically bounce back pretty quick, I think.
So they're getting back to normal activity? What about sexual activity? Did they ever get to go back and do that normally again?
Absolutely.
So the issues that they were having where something was bulging out, that's gone, the pain gone, and their activities. Does it, and usually about 6 weeks, you say?
Yep. Usually we see our folks back at 6 weeks for a post-op visit and sort of reevaluate how are they doing, how are they feeling, and we usually give them the okay to resume normal activity as long as they're healing appropriately, and Dr. Francis says it's okay.
I want to touch on something. Let's go back to this mesh issue, because I don't think you can't watch TV, especially late at night, without someone coming on saying, have you had mesh? And if so, call me up so we can sue the bloody surgeon. Now, what is the controversy with mesh?
Yeah. Well, I think the controversy starts from a point we kind of touched on earlier, where anytime you have a permanent foreign body within the human, there's a potential for that foreign body to kind of work its way toward the outside. It's called an erosion. That really is the only complication out of all of the complications that you can possibly have with pelvic surgery that is unique to mesh surgery. I think what started the whole thing was an FDA warning in 2008. It was updated in 2011, where the FDA basically warned the general population that there were a significant number of complications due to mesh surgeries. The reality is, at that point, the FDA didn't really do a good job of mentioning the fact that there were a large number of mesh surgeries being done all of a sudden because of the development of some new mesh kits, if you will. The significance of these mesh kits was that they made the surgery a little bit, I don't want to say easier, but they made the surgery a little bit, I think that's the only term you can come out, easier to do. And so there were surgeons that were maybe not typically comfortable doing this type of surgery before that started doing the surgery. There were also surgeons that felt it to be much more efficient now that these kits were possible. And so there was a large number of surgeons that were doing these cases now. As a result, as you know, whenever you have a lot more surgeries done, there are a lot more complications. There was an update in 2011 where, again, they mentioned that, or the FDA mentioned that there were a significant number of complications, and one should make sure that their surgeons are educated, and there was a list of things patients should look out for. I think that really kind of sparked the lawyers and the patients and concerns.
Are we still using mesh now?
We do still use mesh, and as you know, there are case reports of using mesh in the 1950s. There are case reports of using some sort of mesh all the way back to the ancient Egyptians. So.
But mesh is not mesh. The mesh that was being used, say, 10 years ago, it's different from some of the mesh products out now, aren't they?
You're absolutely right. I think we've learned a lot about mesh, and that the mesh type should be unique to the part of the body that you're using it. For example, as vaginal surgeons, we started using mesh based on the history of general surgeons using mesh in the abdominal wall. And we've learned that the vagina is actually a lot more elastic and requires to be able to move for sexual function, where the abdominal wall was different. So we've kind of changed the type of mesh we use as a result of that. Now we're using more lightweight meshes. Larger pores is essential. We're a lot more focused on the material the mesh is made of.
So you kind of make a call as to whether or not you need to use a mesh or don't need the mesh when you're operating?
We actually make that call before we go to surgery. We have a time before surgery that we call pre-op counseling, and even before that, when we're scheduling and talking about the surgery to the patient, there are some patients that are just fearful of it, and so we avoid mesh completely in those patients. And the mesh allows you in some situations to do a far less invasive surgery than, let's say, a typical sling would. So there are certain situations in which we say, I think the mesh is probably best.
Heather, do you see a difference in the functional result in patients who've had a mesh versus not having a mesh?
No, I wouldn't say so.
Comes out about the same. So in terms of what you've seen, is there equal satisfaction on the part of the patients, of those who've had mesh put in versus those who had the surgery done without the meshes?
Yes, sir.
Mesh got a bad name, huh?
I think so.
Sounds like what you're saying is that there were some of us doing this that we had no business doing it.
Unfortunately, I think that would be
Which is
fair
the
to
case
say.
in most things.
Yeah.
Tool looks good, so it's a nice shiny tool, and we all want to try it, but we don't
That's right.
necessarily have the training with
And
it.
I don't know that the intentions were always selfish. I mean, there are a large number of patients, women, who might have been neglected of surgery before the mesh kits came around, and I think in some cases the surgeons just wanted to give that patient access to what she.
I think this is one of these issues. I see it a lot with fecal incontinence in my practice, but I think this is one of these things where women complain or may have something or don't know how to bring up the subject to their doctor that they have this problem. If you have a question or even think you may have some issues going on as far as prolapse or pelvic floor problems, please feel free to contact Dr. Francis, and of course feel free to contact your primary physician. And if you have questions about this, again, talk to your gynecologist, but also if you have any other questions, you can contact us at kentuckyhealth@twc.com. I'd like to thank you very much for being with us, Dr. Francis. Heather,
pleasure.
thank
Thanks
you
for
very
having
much,
us.
Ms.
Thank
Lange.
you. I appreciate it.
Sean, thank you.
With a rusty hoop where a kid shoots threes of mine. Corvettes and gold cars, riverboats, from the Osborns to the Goins, barbecue, burgoo, and bourbon balls, from the land between the lakes to the Cumberland Falls. There ain't nothing like my old Kentucky home, so weep no more as I sing this song about the Commonwealth where the sun shines bright in my bluegrass state of mind. Yeah, the Commonwealth where the sun shines